You hear us?
Oh, are we here?
We can hear you.
Yes.
We can hear you. All right. I believe we have a quorum with everybody on here. Let me apologize for all of this. The state IT department is working on it and hopefully it won't happen again, but through some cleverness, we were able to get this moving forward. I do have to say, some of the public may not be able to come in. We have placed announcements for them to see it, but if people watch it later, it will be available as always to watch later on. And if they have questions about the meeting, they can always email the council and get those questions answered for them. So again, we apologize to any public that tried to get in and that can't. But we did the best we could getting this meeting going because we have a lot of work that we want to do. So I welcome you all to the meeting and all who came in through Zoom. And I'll just quickly go through the agenda because there's some changes. We probably will not have public comment that we have, but people again are encouraged to email us with any concerns they want to share with us. We will review the minutes of June and July and vote on them. Andrew Scoggin planning grant update, assessment findings, we'll be here to share. There'll be a chairperson's report. The committee reports are going to move around a little. We're going to do finance, program and grants, and we're going to do governance in the end. They are going to do the presentation on the orientation. So I'm going to leave them towards the end of the meeting. And then we'll do staff reports and new business. Any other changes anyone wants to make on that agenda?
Is there any public signed up for comment? No.
Okay. No, there wasn't anyone who signed up for public comment, so. And we were going to have a grantee spotlight on sanctuary. Oh, we're here, okay, we can still do that, all right. So I'm going to start quickly with introductions so people know who's here. Paul, can you start, please?
Yeah, Paul Vinsel, emergency medicine and addiction medicine physician from West Bath.
Yeah.
Holly Stover, State Representative, House District 48.
Thank you. Pat Kimball, Chair of the Maine Recovery Council.
Chastity Poole, Executive Director of the Maine Recovery Council.
Elizabeth Fortier, Coordinator for the Maine Recovery Council.
Brendan O'Neill, Maine Attorney General's Office.
Maggie McLaughlin, Health and Human Services Director, City of Portland, representing litigating subdivision.
I'm Tess Parks and I'm the Vice Chair of the Maine Recovery Council.
Good afternoon, everybody. I'm Todd Brackett. I'm the Sheriff of Lincoln County.
Okay, we'll start with Betsy.
Betsy Fitzgerald, representing the litigating subdivisions.
Thank you, Joe.
Good afternoon, everyone. I'm Joe Everett, the President and CEO at the Opportunity Alliance here in South Portland, a member of the council, and I chair/co-chair the Program and Grants Committee.
Melissa.
Hi all, Melissa Hackett. I use she, her pronouns. I'm a policy strategist at the Maine Children's Alliance, and I'm the vice chair of the Program and Grants Committee.
Thank you. Liz.
Hi, Liz Blackwell Moore, she, her. I'm the director for Cumberland County Public Health.
Deb.
Hello, everyone. My name is Deb Poulin. I'm the deputy director with the Office of Behavioral Health. I am also the treasurer for the MRC, and I chair the finance committee.
Thank you. Jamar, is Jamar on there? I saw him earlier. Yes. There
Yes.
is Jamar. You want to introduce yourself?
Yes, Jamal Williams, representing member of the Recovery Council, but also representing prison reentry.
Thank you. And Reagan.
Hi, everyone. Reagan La Rochelle, chair of the Maine Recovery Access Project, or I would say board chair of the Maine Recovery Access Project, holding the harm reduction seat. And I apologize that I'm driving, so I may not be able to mute and unmute reliably, but I'll do my best.
Thank you. And you will remind you, Reagan, that if we have a vote, we have to see you visually, or you'll have to abstain from voting. Is Amber on? Okay, I think I got everybody. Did I miss anyone? I apologize if I did. All right. Thank you very much. So first item on the agenda is the June and July minutes. You all had a chance hopefully to review those. And if you wish, can we vote on them together? Do I hear a motion that we accept the June? And
I just
July.
want to say quickly, I wasn't at one of the meetings, so it would mean I would have to abstain. So
We take them up together, so.
Okay, we'll take them separately.
sorry.
No, that's fine, Liz, thank you for that. Okay, I'm looking for a motion to accept the June minutes.
So moved.
It's been moved by Holly, seconded by
Who moved that?
I did, Holly.
Holly? Who's the second?
Paul.
Paul? All right. You ready for the roll?
We're ready for the roll call.
Okay. I would vote yay. Deb Poulin,
Yes.
Holly Stover,
Okay.
Jamar Williams,
Yay.
Joe Everett,
Since I wasn't at the June meeting either, I will abstain.
Liz Blackwell Moore,
Yes.
Maggie McLaughlin,
Yes.
Melissa Hackett,
Yes.
Pat Kimball,
Yes.
Paul Vincel,
Yes.
Reagan La Rochelle.
I don't think I was there either, so I will abstain.
Okay, Tess Parks
Yes.
and Todd Brackett.
Yes.
All right, so we have 2 abstentions and 4 and 7, 8, 9, 11. It passes.
The motion carries. Thank you very much. So now we have the July minutes. If you've reviewed them, and no one has any deletions or additions, and I hear a motion to accept the July minutes.
So moved.
Holly moved and Paul seconded, Betsy.
Thank you. I'm sorry, I can't see you and write at the same time, so. Okay,
Betsy, do
July
you want me to
minutes.
do the roll?
Nope, I got it.
Okay. So you can do a roll of the July.
July minutes. Deb Poulin,
Yes.
Holly Stover,
Yes.
Jamar Williams.
I will be abstaining.
Okay, Joe Everett,
Yes.
Liz Blackwell Moore,
Abstain.
Maggie McLaughlin,
I also abstain.
Melissa Hackett,
Sadly, I also abstain.
Pat Kimball,
Yes.
Paul Vincel,
Yes.
Reagan La Rochelle, Tess Parks.
Yeah.
Todd Brackett.
Yes.
That is an 8-4.
So motion carries. Thank you very much.
Yeah. Yep.
Thank you. All right, so we now have what we call the one of the grantee spotlights, which is Needle Point Sanctuary Low Barrier Employment Pilot. And I believe Willie is on the Zoom. Are you there with us?
He will be, just a second. You want me to pull up his
Hey, welcome, Willie.
Thank you so much for having me. Hi,
Thank
everybody.
you for your patience with our technical problems, so thank you.
Oh, I'm just impressed by how quickly you guys could pivot. Tech issues are beyond all of us. Hi, everybody. My name is William Hurley. I'm the Executive Director of Needle Point Sanctuary. Council, are you able to share the presentation I prepared, or would you like me to share my screen?
We can pull it up. We can pull it up.
Okay, great. So I'm here to talk about a project that Needle Point Sanctuary started informally 2 years ago, and we formalized it in January of 2025 with support from the Maine Recovery Council, as well as with support from the Maine Health Equity Foundation. And the name of this program is the Low Threshold Employment Program. And it lasted from January 2025 until April of 2026. During these 9 months, we employed 7 individuals, and 5 of those individuals completed the full program. If you don't mind going to the next slide. The purpose of the program was pretty simple. We wanted to provide employment to people who were in the midst of struggling with substance use disorder and or people experiencing homelessness. And the individuals that we hired were all people currently experiencing substance use and currently experiencing homelessness. The goal of the program was to improve our organization's services, improve health and social outcomes for those employed, and to model the project as what we believed it would be, which was a means of best practice within fields related to drug user health broadly. Next slide. And there's a couple of different graphs that I wanted to show you all. So all of the data generated from this project, it's not, there was no IRB approval. It's a very small sample study. So none of it is statistically significant, but we think it does represent something very promising. So like I said, there were 7 individuals that were employed. Very quickly, 2 of those individuals got caught up within the criminal justice system and were unable to complete the employment. We were able to do an initial survey with one of them. At the end of the project, we were able to get technical assistance with the Texas Harm Reduction Alliance, which operates a similar program. And through conversations with the Texas Harm Reduction Alliance and some other programs across the country, what we discovered was that while we're not the only syringe service program or drug user health program that provides employment opportunities such as this, our program was unique and pretty singular in that the individuals we were employing were actively experiencing homelessness and continuing to struggle with substance use disorder. So typically within these fields, it's an established form of best practice to employ people with lived experience, right? I know the Maine Recovery Council has many people with experiences of recovery. I myself am in recovery. That's how I got into the field that, I continue to work in, was through my personal experiences. But this was kind of a new venture to offer direct employment, right? We weren't doing contract work. This was W-9, full employment at about 5 hours a week and integrating them into our services in various capacities. And at the end of this, I included some of the recommendations from the technical assistance that we did with the Texas Harm Reduction Alliance. Next slide, please. So this is the initial demographics of our low threshold employment cohort. There were 5 men and 1 woman. 100% were Caucasian. The average age was 38. As I said before, 2 individuals were unable to complete the program. We've got some demographics related to education, with the majority having their GED, some having not graduated, and others having their high school degree. The majority of them had been experiencing homelessness for over 3 years, and then 2 to 3 years and 1.5 years. And 100% at the start of the project were unhoused, living outside. They were not accessing shelters. They were not couch surfing. They were typically living in tents outside. Next slide, please. So again, 100% were experiencing homelessness. And we also surveyed some self-identification about how people understood their substance use. And this was an interesting one. I didn't include the 6 months data from this, but I'll talk about it a little bit, because we had 83% of people articulating their substance use as causing them problems, but mostly under control. And of course, this is a subjective question, a subjective answer. And then what we saw at 6 months was a greater degree of articulation of people understanding their substance use as chaotic, right? So what we kind of felt through that experience was that there was a greater openness in people's ability to articulate where they were at with their relationship with substances. 14.5 was the average age of people starting to use substances. So we also saw that people's experience with substance use started pretty young within this cohort of people, actively experiencing homelessness in Bangor. Next slide, please. So this is the 6-month follow-up, and we immediately saw an impact on the housing situation of those who were employed. So 2 out of those 5 individuals were able to access housing in the first 6 months. And that was through working closely with their caseworkers, through the additional income that they were able to earn as an employee of our program. So you see the metrics there. And some people kind of transitioning from, completely, unhoused outside to unstably housed, right? Which is more couch surfing opportunities, occasional stays in hotels and the like. Next slide, please. And the closeout survey was the most promising and significant in our view. And what we saw was that 80% of the individuals who'd been employed through our program were stably housed and continue to be housed. And the remaining 20%, which is one individual, they have their voucher and they're looking for housing currently. So we were able to kind of see this direct impact on people's housing situation. And what we essentially saw was that, a part of the model that we pursue at Needle Point Sanctuary, and the way that I articulate this is pretty informal, but I view it as a success if I'm able to get someone who is spending 99% of their time in a tent using injection drugs to come into our program for 4 hours and access services, to come volunteer with us, to come, and be in community with me and my staff. I view that as a tremendous success. And so this employment model was that, times 1,000, right? Because what we saw were, individuals in the midst of pretty difficult circumstances, spending a lot of time with our staff and with our program participants in a professional environment, right? So they're spending time with our recovery coach, with our peer support specialist. They are learning valuable skills. They were attending, trainings conducted by the state CDC, participating directly in things related to the ongoing HIV outbreak in Bangor, right? Being, full members of our staff who are really able to do things that other staff couldn't do, right? So part of where this project comes from is an understanding that not only are people with lived experience well suited to do work related to prevention, harm reduction, treatment, and recovery, but for myself, I've been working at harm reduction programs since I was like 25. And I'm on 8 hours, sometimes 12 hours a day, right? And those are 8 to 12 hours where I'm connecting directly with people. But for our program participants, they are living at 24 hours a day. 24 hours a day, they're in contact with their community members who are struggling in similar situations. And there's a lot of unpaid labor that happens in relation to the work of harm reduction and recovery and all of these things. In particular, as it relates to overdose response, where we know that people who use drugs are responding to the majority of overdoses. We do a monthly meeting of the Maine Recovery Alliance, and Gordon was able to come to it that time. And we did a little exercise where we had everyone in the room raise their hand if they'd responded to an overdose before. And everyone in the room raised their hand except for the state employees and CDC staff who were present. And then it was keep your hand up as we kept counting, right? And over the course of 2, 3, 4, 5, 6, like me and my staff, we dropped our hands. But many of our program participants, more than half the room, kept their hands up as the count just went up and up and up and up. So we know that, people in the midst of these experiences are able to connect with their community in ways that we can't outside of the typical boundaries of the work that we do. And this employment program was a way of trying to recognize that and kind of incorporate it within the services that we do. And many of those metrics are difficult to measure for a ton of different reasons, disruptions in services, changing landscapes, and things like that. But we saw it day in and day out. Next slide, please. And we also saw that there was a significant uptake in individuals accessing medication-assisted treatment. And as part of the program, each staff person within the low threshold program was paired with our peer support specialists. So they worked closely with the peer support specialist who did not really engage in the dual role of like employer and peer support, right? Like that was kind of their role, was to provide peer support to those individuals, help them access additional services. And one of the outcomes we saw related to that was medication-assisted treatment, in particular, greater access to the methadone clinic and attendance at the methadone clinic. And of the 5 employees who made it through the entire time period and didn't experience disruption, 100% of them were surveyed and said they would want to continue being a part of this employment program and to be employed at Needlepoint Sanctuary in the future. And in terms of the transition that we did at the end of the time period, what we did is we did a period of technical assistance, and we have created a participant advisory board. And our participant advisory board is made up of all of our former low threshold program employees, and they receive a stipend weekly. And we are hoping to continue the program and pursuing funding to continue it, and those individuals would have priority in hiring. And the participant advisory board currently meets once a week on Mondays. Would love to extend an invitation to any member of the Maine Recovery Council, or really anyone here who would like to meet our participant advisory board. They function to provide lots of information to our staff, to me directly, to workshop how our program can improve and better serve the people that we are working with. Next slide, please. And these are just a couple of self-reflection narrative responses from the staff or employee in the program. The thing that came up the most was the sense of purpose and belonging, right? That there was this constant articulation that this program gave me purpose. This program gave me a sense of belonging. Someone said it's given me options for recovery when I'm fully ready. It gave me a place where I felt welcome and not judged, a sense of belonging and well-being that helped with my relationship with drugs. It gave me a place to belong where I didn't feel judged, a home base to access other services. It helped me to get a second chance at being a normal member of society. And they said, well, I wouldn't say normal. You would have had to hear it to really get the full picture there. And really articulating to people who were program participants that they have this degree of agency and expertise that really can be translated into career opportunities if they are able to access the services that they need to change some of the conditions that are present in their life. Next slide, please. So, the clearest success, we outlined the initial goals at the beginning, and the clearest success was improving the health and social outcomes of those employed, right? We see the metrics related to housing, medication-assisted treatment, and there were also successes in terms of improvement in our services generally. I think our cultural competency increased. It's difficult to measure metrics of naloxone distribution and other traditional metrics for syringe service programs, because during that time, our program, we didn't have the brick and mortars that we have now, and the encampment that we were working at was swept. So there are some interruptions there that impacted the volume of our services. But alongside these successes, there were also challenges. Next slide, please. The biggest challenge was kind of reconciling the reality of low barrier employment with the accountability that's inherent within employment, right? That we are trying to engage, our staff were engaged in these dual roles at times, most of which fell on me because I was kind of the point person for the project and working closely with people in terms of like scheduling, training, accountability, follow-up, and all these things. And it impacted my ability as, you know, my background is in peer support and recovery coaching. And it's hard to establish that sort of relationship with someone while you're also, you know, having to give them a hard time for being late to work or what have you, right? The other challenges that emerged were navigating carceral systems, right? We saw people that we employed through the program pretty quickly get swallowed up within the criminal justice system and not reemerge for a period of time. There were also challenges with individuals who are on probation. And I think that part of the challenge related to Needle Point Sanctuary is a small community-based organization. We've been around since 2018, but in terms of being, having staff and funding and really building out relationships in the community, that's the last couple of years. So we would find ourselves in a situation where we'd be trying to communicate with probation or different kind of institutions within the community. And there wasn't great communication, and we weren't really able to support the people in the way that we would like. And oftentimes there was some stigma, right? Like we would even encounter caseworkers who would say negative things to the employees of the low threshold program because they were working at a syringe service program. And there was a perception, in particular amongst not all of the probation officers, I can't really speak directly to them. There was a sense that there was this perception that our program wasn't going to be beneficial for their housing journey or their recovery. And then there were also social impacts within the unhoused community because pretty much every one of our program participants wanted to work for Needlepoint. And so you'd have people kind of like competing, you know, for the attention of staff or bugging us about like, hey, when are you guys going to hire so-and-so? Or, hey, why did you hire so-and-so and not me? So there were really, we did not anticipate some of the social impacts that were going to occur within that community itself related to the program. Next slide, please. And in terms of next steps, we have, we worked closely with the Texas Harm Reduction Coalition. We incorporated a lot of their feedback. We have created a policies and procedures manual, which is in review right now by the Participant Advisory Board and our staff. So it's kind of a collaboration between the former low threshold employees and the entire team. That board provides consultation and guidance and is receiving a weekly stipend. My board has given me the permission to pursue funding to formally reintroduce the program with new policies and procedures in place based on lessons learned and technical assistance. And once we have sufficient funding for it in place, we're going to move forward with the program. And we were operating this program with about, I think, $90,000 in funding. And we were also operating at a time when our program was really small. And I don't think we had a good ratio of like full-time staff to the low threshold employees. So we had 4 low threshold employees and we had about 4 staff too. So I feel our organization has grown since then. And if it was a program that we were incorporating for the first time now, I think that some of the challenges would have been mitigated because it was oftentimes difficult to engage with the program in the way we would have liked alongside everything else happening. I mean, it's been a crazy couple of years in Bangor, everybody. I'm not sure people's degree of familiarity, but between, the HIV outbreak, the closure of Health Equity Alliance, homeless encampment sweeps, and then internally we're a program going from the grassroots to becoming a certified state syringe service provider that's growing rapidly and building up its financial and administrative capacity. But overall, we're very happy with the results. We want to be able to continue the program We also want to be able to eventually work with researchers to do some studies on the program itself, really, and try to narrow down the specific features of this program that assists with people's journey towards housing and recovery. And thank you all for taking the time to listen to my slideshow, and I'm happy to take any questions.
Well, first, thank you for sharing this with it. From the look of it, from my end, it's Pat Kimball, you certainly invested the funds that you received from the opiate settlement to save and help lives. So very much appreciative. And someone from the Bangor area, I know that it wasn't always an easy haul. You certainly have had some struggle with stigma in the area, and I appreciate the work that you're doing. So thank you very much. Does anyone from the council have any questions that they have? Paul?
Yeah, really, thank you very much. That was a wonderful presentation. You said that you feel that you'll need $300,000 over 3 years to continue the program. What are some of the sources you're looking at for that money?
Yeah, so we would be looking at private foundations, such as the Maine Health Access Foundation, other private partners. We're trying to kind of cobble it together from a few different sources at this point, whether it's like smaller grants to facilitate peer support meetings that they engage in. And then there's, of course, I think the prospect of future settlement funds, whether at the local, county, or the state level here. As of now, a lot of the funding that went into this program, there were specific funds that we were able to get, such as the $20,000 from the Maine Recovery Council. But we're really blessed the last couple of years with the flexibility provided by the additional opioid settlement funds that were provided to syringe service programs, because there was a pretty significant infrastructural challenge related to this program. I mean, even something as simple as getting everyone into the payroll system, what it actually required was getting everyone identification, opening a bank account. A lot of the things that we take for granted and we don't even think about were things that we had to build out as this program started. And so there are a lot of hidden costs. And that's why I put the, basically $100,000 a year, because we were able to get through it with about 90,000. So I think that 10,000 would give us some extra wiggle room.
Thank you. Holly, you had a question?
I had a question. Thank you for your presentation. My question is about your county opiate settlement funds. What is your county doing currently? And I'm just wondering if they could assist in Penobscot County.
Yeah, I think we'll be speaking with the county again. My analysis of the differences between the county and the state. So we and the municipality, we are receiving a grant from the Penobscot County Commissioners for our recovery coaching program. And that pays for the salary of our recovery coach. And we also got a smaller grant from the city of Bangor for the recovery coach. So we're able to bring him to full time. My sense is that the county and municipality are going to be more reluctant to fund a program such as the low threshold program, or fund anything that is more explicit in terms of an articulation of harm reduction, if that makes sense.
It does make sense.
Yeah, the recovery narrative and recovery services seems to be the safer avenue for pursuing opportunities at the municipal and the county level.
Thank you. And one follow-up to that. Have you reached out to the Department of Labor, to Commissioner Laura Fortman around labor?
That would also be super helpful, whether it's a follow-up email or anyone can connect with me directly. I really want to, Department of Labor, there's organizations that I'd want to work with, such as the Eastern Maine Development Corporation. I'm interested in other kind of alternative employment models that other nonprofits have done to really kind of figure out a different aspect, some other aspects of the program.
I think reaching out to Department of Labor and Commissioner Foreman would be a great idea. They have at times had some money, workforce money. I don't know that they do right now, but she's extremely knowledgeable of the
Thank you.
need for employment.
Thank you. Any other questions? Not seeing any hands online. So, Lily, thank you very much. And in full disclosure, I'm on the Penobscot Opiate Committee. All I can say at this point is keep your eyes and ears open. All
Yeah.
right.
Thank you all so much.
All right, thank you very much. It was a very positive outcome, and thank you. Thank you. All right. We're going to move on, if there's no more questions, to Androscoggin County Planning Grant update. Just a reminder, so everyone knows, that the council originally gave to Androscoggin 1.5 million to Androscoggin and Franklin County to expand detox in December of 23. That eventually changed $400,000 to each county to do a countywide assessment with the ability to request the unused remaining funds to implement a project based on those findings.
I just want to clarify, we didn't give 1.5. We originally voted to award 1.5 to each county for detox beds, and then that changed to.
Yeah, they came to us and said, that's not what we really need. This is what we'd like, and so therefore voted to change that allocation to give them an opportunity to do a planning grant. So that's just the background for those who didn't know. So at this point, I'm going to turn it over to Androscoggin County Planning Grant Committee.
We have Corey, Emily, and Rowan all on deck. So I'm just gonna pass it to whichever one of you want to jump right in. And do you want to do your slides or do you want us to run them? What's your preference?
I don't mind sharing. I have it up. So
Okay, perfect.
I think I just need permission.
Yeah, I think you have to hit share and then I'll get a request.
Okay. Just sent it.
You should be good now.
Perfect. Thank you. All right. So good afternoon, everybody. My name is Rowan McFadden. I work for Healthy Androscoggin as a coordinator. And part of my role in this planning grant process was really helping to pull together this assessment in collaboration with USM. Let me just get this presenting. I'm used to doing Canva as opposed to PowerPoint, so it's a little different for me. But what I'll be presenting on today is the results of our data collection for this assessment that we have done. So to get us started and give you all a little bit of background on our goals and methods. So in 2025, we were funded through the council to conduct this needs assessment. Prior to that, we had been awarded a overdose prevention grant through the state, which I conducted a much smaller scale needs assessment, which had pretty severe limitations as it was just me who was able to go out into the community and pull this all together on only 20 hours a week. So that initial assessment in 2024 helped to also inform this assessment that we're doing today because it really highlighted the gaps that we were looking to fill in terms of knowledge around what the needs are in Androscoggin County. So we contracted with the Substance Use Research and Evaluation Team through USM, the Catherine Cutler Institute, and they really helped pull together all of the data collection pieces and ran all of this stuff in the field for us. So some of these strategies were designed to really get targeted feedback from our identified priority populations, which were people experiencing homelessness, youth, and individuals with lived experience. And really the assessment process focused on identifying actionable insights to improve our access to services in the county and reduce overdoses. So the primary goals of this assessment were to gain a better understanding of our current gaps kind of across the continuum of SUD services. Also, to get a better understanding of community and population-specific needs and barriers, with an emphasis on our really underrepresented populations. And finally, really highlighting what is working and what isn't for targeted improvements with the greatest impact. Our data collection approach involves a series of focus groups, interviews, and a community survey. We heard from about 97 members across our community with a focus really, again, on our unhoused folks, our youth, and our people with lived experience. Participation was incentivized for our youth, our people experiencing homelessness, and our community members at large. Most folks received a $30 gift card for focus group engagement. Additionally, collection of data occurred both virtually and in person to allow for the greatest impact and enhance engagement. So all of our data was audio recorded and transcribed verbatim. These notes were summarized, and then software was used to identify kind of cross-cutting themes that we'll look at in a little bit. For this report purposes, we broke it down into prevention, harm reduction, treatment, and recovery for our responses. So just a quick summary of our data sources. So we had a really great participation from individuals experiencing homelessness. We had about close to 40 folks show up across our 2 focus groups that we held at the Opera and Drop-In Center. Additionally, we got a pretty great youth turnout as well. We had 27 youth that we were able to engage across our focus groups. We had about 9 key informant interviews. Those were specifically focused on some of our leadership within hospitals, law enforcement, and first responders at large. So that's just a quick breakdown of kind of our numbers of representations for the data sources. Now for our key findings. We will start with barriers in the SUD care continuum. Barriers are driven by system gaps rather than issues with providers or programs is really the high level finding here. On a professional level, some of those gaps included missed windows of opportunity due to system delays, health-related social needs posing complex access barriers, and additionally, a need for more uniform familiarity with the SUD landscape. At an organizational level, some of those barriers looked like fragmented transition points, specifically after jail and hospital discharge. Another thing that was really stressed was a lack of infrastructure to make connection between organizations. As we'll see later in some other comments, there's much more reliance on relational referrals as opposed to consistent pathways that can be utilized post-discharge. And then also fatigue with systematic changes was another thing that was very emphasized at an organizational level. Looking at an external and community level, really feeling there was an inadequate social service infrastructure, feeling overall insufficient capacity across all domains, with workforce really being the key, insurance and grant funding gaps and funding instability, and then finally, stigma is a pervasive structural barrier, including damaging fallout and loss of harm reduction spaces specifically. So kind of breaking down some specific quotes we had from overall barriers to access for services. A lot of individuals, particularly our folks experiencing homelessness, noted that wait lists are just too long. A lot of people, this first quote here, 14 months to get a provider, 14 months of waiting to be seen for whatever the concerns were. And then again, feeling insurance is an issue for accessing treatment. Some healthcare professionals stating that they feel like there's not enough detox beds. That was one of the only comments, surprisingly, around detox beds. Mostly it was about difficulty accessing services, period. Then looking at some capacity barriers, we're seeing that like people with lived experience stating that a lot of people die because they're lost in the shuffle. These wait lists are too long. and people go back on the street because beds are full. There's not enough sober housing that's transitional space in particular that's immediately available. Moving on to facilitators within this continuum, kind of our high level here is strong relationships and outreach efforts are really driving what is working well. So looking at our professional level, we have strong but largely informal pathways to harm reduction services, options and peers specifically. Most like what Willie was mentioning in his presentation, it's really the peers that are providing these services, especially with some of the loss that we felt in Androscoggin County around our syringe service programs. Also, improving care coordination via casework and options liaisons for treatment has been working well. Increased capacity for medication-assisted treatment, specifically for opioid use disorder and related groups, has seen improved access. Looking at an organizational level, we have a really robust collaboration when relationships exist, but again, because of that lack of formalized pathway, there's still some gaps. Peer support as a philosophy and approach is becoming foundational, which is fantastic to hear. Then looking at our external and community level, we have strong community-based cross-section collaboration. So through our Lewiston Auburn Area Recovery Collaborative, which is the coalition that I facilitate as part of our overdose prevention grant. And then really great collaboration between clinicians, public health, and law enforcement. And we're seeing that lived experience and peer influence are highly valued, and also seeing there are efforts to reduce the stigma, particularly around our harm reduction spaces and services. So just some quotes that stood out thinking about facilitators. So within the collaboration and coordination, we're seeing that, the thing I probably noticed, I think in the last probably 2 years, is in this area, there's less of a siloing effect. There's been a lot more partnership and people are joining forces. Then looking at some of the expanded infrastructure, some of our folks experiencing homelessness, we're saying like at least there are community health workers that are coming out and meeting people where they are. They come find them instead of the reverse happening. So let's talk a little bit about some of the key findings we have for prevention. So starting with what's working, key informant interviews really showed that strong community partnership is really working well. We have, again, the philosophy that treating adults with SUD is essentially child and family prevention, which is fantastic. We're seeing this idea that it is a whole family approach, not just an individual approach. Most participants also agreed that there is trust in community-based prevention and that there is an increase in efforts to include people with lived experience. Several participants also shared enthusiasm for and awareness of prevention-centered community events, which is great. And then we have just some quotes from our key informants around what they feel is working in our prevention space. So thinking about gaps within prevention, really the biggest theme to come up again and again is chronic underfunding of programs, or funding that is so incredibly specific that it doesn't allow for long-term projects to be undertaken and collaboration to occur effectively. Also, feedback from people with lived experience, as well as professionals, indicated that while school-based prevention is happening, it's really not uniform in any way or any region across the county. And that some parents feel that as as well as administrators opt out and like kind of sweep some of this under the rug. Sorry, that was a weird sentence. But really that idea of if it's put out there to the parents, a lot of folks are pulling their kids out of prevention programming. Also hearing from youth that they feel that hearing from peers or those with lived experience is more valued as opposed to having adults come in with prescriptive or kind of uniform prevention programming. Also, most participants agreed that there really is value in prevention strategies for parents, families, and community at large, and also outside of school-based programs. And then again, feeling that there needs to be improved messaging within the community as a whole around prevention activities that are occurring, whether it's at a community level or a school-based level. Up next, we have our harm reduction findings. So same structure, what's working, and then we'll talk about what's not. People really feel that informal pathways, again, are what's working best when it comes to harm reduction. Options is also used, and it's the most formal linkage that we have right now to services. Harm reduction outreach on foot when available is the most effective approach that we've heard from our folks experiencing homelessness. And they report that that model helps build trust faster than compliance-driven or punitive approaches. The loss of physical space for harm reduction services is very acutely felt in our community, indicating that really additional brick and mortar service delivery continues to be impactful for our community. Another great thing to highlight is everybody interviewed knew how to access and use naloxone, which was amazing. So looking at current gaps within our harm reduction in Androscoggin County, again, stigma remains a really driving factor that limits infrastructure and access, ranging from really insufficient information and signage to service instability, program closures, and setbacks associated with program closures. Participants also reported either not knowing about harm reduction services spaces or difficulty finding information about where to access those services and how they operate. We still do have one brick and mortar facility for SSPs within Androscoggin County, but information is somewhat difficult to find for folks. Also, reduced serviceability and poor geographic accessibility. Prior to the closure of one of our SSPs in Androscoggin County, it was much easier for members to access those services. With that closure, it's been really acutely felt. Also, it was strong agreement among healthcare professionals and everybody else interviewed that there really needs to be a regular mobile unit for outreach. Because again, kind of harkening back to the previous comment, meeting people where they are builds the trust faster and allows for better accessibility of the services. So looking at treatment next, what we have that's working well is agree that like low barrier, meeting people where they are at is the most effective and prevailing philosophy within our SUD service community in the county. Professionals and key informants describe successful emergency department practices for MOUD initiation, and there's hope that a soon-to-open crisis center will help ease some of the capacity burden that's been happening within our ERs in the county. All adult participants noted there are local withdrawal management services within the hospital system, specifically our detox services. Healthcare professionals reported that outpatient services are accessible in larger communities and towns. I think that specifically accessible in larger community and towns is important to note because our rural populations are chronically underserved and all of our services only exist within Lewiston and Auburn in Androscoggin County. Participants also noted that peer supports and reentry navigation defer people from slipping through the cracks, but more is needed. What our gaps look like is there's a widespread agreement that there's really a breakdown in continuum of care in Androscoggin County at service transition points, specifically at hospital discharge and when individuals are released from jail. Key informants and clinicians noted that post-hospital discharge is especially vulnerable for persons with moderate complexity, and there are very limited options for these individuals who need like additional stabilization following discharge. Feedback also suggests that care transitions are overly dependent on staff's interpersonal and organizational relationships rather than the standardized pathways. Further exacerbating these breakdowns in continuity of care are wait lists, eligibility issues with insurers, including Maine Care, housing, transportation, childcare issues. Several of our key informants and people with lived experience noted that workforce turnover really interrupts care as well. Our recovery findings. What we have that is working well is several participants noted that over the last several years, there's been a really great boom in terms of sober housing and innovative recovery housing models, particularly our LGBTQ plus inclusive housing and women with children housing. We have, I believe, around 7 or 8 different recovery houses in the county, but the demand is still so high, all of the beds are consistently occupied. The recovery community feels that there is strong peer leadership and reentry focused recovery work, particularly with Maine Reentry Network and the work that they're doing within our county. Our folks with lived experience and key informants agree that the best approach to recovery is that it's long-term and holistic, and they believe that the area's recovery community also adopts this philosophy. So our current gaps that we see within our recovery infrastructure is really, again, a severe shortage of transitional and recovery supportive housing, and a sizable population of persons experiencing homelessness who need these SUD services. There's also an overwhelming agreement that the lack of a fully resourced recovery community center in the region is a major gap for individuals seeking recovery services and connection. Also, a lack of sober social spaces and employment pathways, and that transportation is always an issue, even if you're living in the city centers, and it just gets worse and worse as you move to the rural parts of our county. Key informants also noted that over-reliance on volunteer labor and single staff programs and a scramble for funding streams make it really difficult to manifest these spaces that are needed. Key findings kind of broken down by our priority populations. So challenges from our youth perspective is really the normalization and visibility of substance use within our county, feeling like there's a lack of safe space and a lack of youth-only space. What they identified as support needs are really guidance based in evidence rather than punishment, and improve substance use education opportunities for parents and caregivers. And how they really want to see us engage with them is through social media and in a really effective way that's not super formal, but provides prevention messaging that is accessible for them. And they really want a seat at the table to develop these materials that will then be put out to the broader community. Yeah, and I think the quote at the bottom here, like there are not enough safe, fun, and healthy places. There need to be more places and activities specifically for youth. Perspectives from our unhoused folks. Most people experiencing hopelessness agreed that for them, there are really few options for long-term residential treatment or recovery housing. And on top of that, affordability of housing in general feels like an insurmountable barrier, as well as stigma is a major barrier in terms of accessing services, and that can really feel incredibly limiting. So just some of the quotes we see here around housing. There are houses out there, but they've been shut down, abandoned buildings, not being used. Is there sober housing? Not here. We're on a wait list. Around stigma, we've already got us labeled. They're not giving us an opportunity. In terms of accessing services, there are so many hoops to jump through. It just adds to a sense of hopelessness. Now, from our data points to action that we can take. So this is, again, just our programmatic level insights that we have emphasized throughout this presentation. So with prevention, collaboration helping with deduplication, shifting away from scare tactics, kind of moving toward, as the needs, limited prevention for younger children. So with, I think for us specifically, a lot of our funding can be prohibitive in terms of age. So prevention services before age 11. Short-term restrictive funding, unstable school-based models with resistance there on an administrative or parent level, easily accessible, judgment-free sober spaces is also a significant need. When we're looking at harm reduction, limited geographic reach, funding instability, transportation barriers, treatment, our gaps and needs. We've got care navigation at transition points, wait lists, and care disruptions, insurance challenges, workforce shortages. And finally, our recovery, we've got the weak recovery infrastructure that was highlighted, housing instability, employment and reintegration barriers, and lack of sober social spaces. So primary system level insights, findings consistently point to system level gaps, not programmatic issues, indicating a need for coordinated infrastructure focused solutions. Below is a summary of those key insights that we've just gone through. And everyone will get a copy of this too. I know I'm kind of breezing through a little bit. There's just a lot of information and I want to make sure I get it all to you in a timely fashion. So looking at high impact system investment priorities. So build the infrastructure needed to sustain continuity of care and support recovery. So some of these priority system investments can look like providing flexible multi-year funding for coordination and system building activities specifically, embedded transportation supports across our continuum of care, development of durable referral and cross-sector collaboration systems, strengthening peer and behavioral health workforce infrastructure, creating standardized pathways for hospital and jail discharge, expanding recovery and transitional housing capacity, and establishing a recovery community center. So why these particular investments matter? Finding suggests that greatest barriers are not deficiencies in individual programs, but really weaknesses in the infrastructure that connects people to those services and supports long-term recovery. Investment in that strengthen this continuum of care, housing stability, transportation access would really help with having the greatest impact on all of these areas. So investment in services that directly engage and support individuals specifically, that would look like investment in family-based and early prevention programming, increase in mobile harm reduction services, expansion of outreach and peer-led engagement models, support reentry and transition navigation programs, expand recovery coaching and peer recovery supports, development of sober social space, recreational, and recovery supportive spaces. So in summary, sustainable impact will require really focusing on both programmatic level activities and system level investments that improve the continuity, access, and long-term stability. So based on assessment feedback, these priorities really look at outreach and peer-led models, recovery infrastructure, transition supports, embedded transportation, expanded access to safe and stable housing, and flexible funding that compensates for care coordination and continuity across the continuum. And to wrap us up, we have a key informant quote that I think is really impactful. I'm just going to tell you that what I've learned in the past 15 years is if we sit in our nice, well-appointed offices and wait for people to come to us, they're going to die. We have to be out in the community. We have to be visible. We have to build trust, and we have to follow through on the things that we say we're going to do. We have to be excellent collaborators and build trust with providers as well as the people that we're serving. And that is officially everything from my presentation. So I will stop sharing and open it up for any questions or comments folks have on the findings.
Your quote was well there. Okay, I have a couple questions here, but ask any members of the committee if they have any questions in regard. Paul?
Thank you, Rowan, that was informative. One of the suggestions you have is mobile harm reduction services. I believe that both Lewiston and Auburn city councils have voted to not allow mobile syringe service programs. Is that correct?
That is incorrect. I know that there is an ordinance before the Auburn City Council right now around SSPs, but they have yet to make any final decisions.
Okay, thank you.
Of course.
Holly?
Thank you for the presentation, Rowan. My question is, do you have a date for the crisis receiving center when that's expected to come on? I've transported people down to Portland to Spurwing's living room project and have had an incredibly positive, they have had an incredibly positive, I just happened to be witness to it. For people who immediately engaged in treatment there, immediately received their prescriptions and immediately got appointments for follow-up. So when's yours gonna open?
I believe there were just some open houses. Corey, I know you
Yeah,
can.
I can actually answer that one. So they had an open house. It is again through Spurwink. But it's not open to the public yet. They're just waiting for some final regulatory approvals before they open, but they anticipate that happening by the end of the month.
That's great.
Thank you. Yes?
Hey Rowan, Corey, this is Tess Parks. I really appreciate the attention to detail and all the information you provided us. And piggybacking off of Paul's question, for harm reduction, you talked about some of the gaps and barriers being lack of geographic coverage, transportation, and I believe you had cited the loss of one of the brick and mortar sites. From your work with this needs assessment or what you've heard on the ground, what are some of the health impacts that is having on the community where individuals are maybe not having adequate sterile syringe coverage or access to other harm reduction supplies?
Yeah, I mean, what I've heard some of is reuse of old supplies, and just additional, wounds happening as a result of the reuse of the older supplies because people are not feeling like they have access points that are as easily available as others. But beyond that, nothing incredibly specific, but I would also like to know more about that specifically.
Thank you. Thank you.
Of course.
Maggie, did you have one? Okay. So I do have a quick question and for sake of time, if you can be as succinct as possible. So what are your next steps and what are you requesting for funding?
Emily, do you want me to answer that or? Yeah. Okay. So our next steps is first for you to approve the assessment findings. And then as part of the funding that we received to conduct this assessment, we have to provide $200,000 to a project in Androscoggin County as a pilot. For those of you who don't know me, I apologize. I neglected to introduce myself. I'm Corey Brown. I'm the Executive Director at Central Maine Community Health, which houses Healthy Androscoggin. So we have to choose a project in Androscoggin County to provide $200,000 to as a promising or pilot project. So after today, once we do that, we are establishing an RFP process for that funding, and that will go out tomorrow or Monday. And then hopefully at October's meeting, you have to approve that project. So we'll be back to get approval for the project that was chosen through an RFP process.
So I just want to clarify for everyone here and make sure I'm saying it right. This is actually what's in the contract that we agreed to, that the Maine Recovery Council and Healthy Androscoggin agreed to. So what you're asking today is first that or it can be in one motion, that we approve the findings of your planning report and that we approve of $200,000 to be RFP'd out in the community.
The 200,000 was already approved.
One second, please, 1 second.
Yeah.
Just want to clarify that.
We don't need a motion to approve the assessment.
Okay.
That's part of it. It's just so you guys all know. When we will need a motion is when they decide what they are gonna give the implementation money to. And then that is something we'll need a motion and a vote on so we can amend the contract and they can sub-award. I think with that, for clear understanding, because like the assessment evaluation a lot, I think if you could just like tell them the strategies that you've narrowed it down to for your RFP.
Sure, we can do that. And thank you for that clarification. Okay, so I'm sorry, I just need one moment to pull that up. And I can do that pretty quickly.
Or if you'd like me to talk about the three, I'm happy to do so. I've got
Oh,
them
do you
up.
have it up
Yeah.
already?
Yep.
Awesome, thank you.
So we were able to again narrow it down to three from the needs assessment. The first is a whole family centered interventions, innovative evidence informed programming that aims to reduce root causes of substance use disorder, increase protective factors across the lifespan, and engage the entire family system rather than focusing on one individual. The family system can include children, parents, guardians, and other supportive individuals. The other one is transition of care, programs that address systematic solutions to ensure individuals and families continuity of care as they transition between levels of care, treatment, recovery levels, touch points, and et cetera. The proposed programs will focus on community infrastructure, capacity, collaboration, and communication. And then the last one is increase safe spaces in the community, programs that create or expand safe spaces, whether for youth, families, and adults. And the proposal will address accessibility and violence as a main barrier to spaces. Safe spaces are defined as intentional environments designed to provide comfort and support.
Can you be a little more specific on the transitions of care? Can you give like an example of transition of care?
Yes. So going back to the assessment, transitions of care could be anything from being released from jail or being released or discharged from a hospital. It could be going in between detox to a sober living house or back out to the community. It could be anywhere along that continuum, that transition where people clearly identified people were getting lost. And so it could be, the project could be any part of those or multiple prongs of those transitions.
Thank you.
So we do not need to vote on the report and we look forward to hearing about your RFP and how that goes. But if there's no further questions, we thank you very much. Oh, Liz, you have your hand up, sorry.
Yeah, sorry, I just wanted to say, thank you so much. This was great. I had read through it before coming, and I was thinking about how much this aligns with what we see too. So I just want to like say that if I were just even to the council, like what you all have discovered here from this really in-depth assessment is really mirrors so much of what we see in Cumberland County as well. And so anyway, so I appreciate it, and I'm excited to see what proposals you get, and that will be great for if you come to us with a final one that you've chosen. If you don't mind sharing with us some of the other ideas that people came to you with, it would be really helpful for me, even if it's, you don't have to share it here, but if it's shared in a document that we could see, it's just helpful for us to see what are people innovating and thinking about and of how to really solve these super complex issues. I think it would be helpful. And because one of the things we had identified early on here too was this need for more coordination between things that are happening, between prevention, harm reduction, recovery, treatment, and also that kind of transitions of care. So that was something we had all identified, and lots of counties and lots of public health regions don't have that. So I think it would be cool to see what are people proposing to do. So thank you.
Thank you, Liz. Thank you. extremely interesting, and again, always looking at, we're glad that you spoke up when we originally determined the money, and you spoke up and said, can we do this planning grant instead of doing it the other way? And very much appreciate it. I think your results were, again, as Liz said, actually mirrored what we were hearing. So we look forward to hearing from you. Good luck with your RFP, and we will be talking soon. Thank you very much.
Thank you, everyone.
Thank you all.
With that, I have a question. So initially, Andrews Garden Common was awarded 1.5 million for detox, and we changed that to 400,000 for this study and then their pilot project. Is that other $1,100?
Both counties, that was originally 1.5 million to expand detox beds. We changed it a couple times, but what it ended up being is 400,000 to each of those counties to do an assessment, and then they could implement. And then 1.1 to Milestone for stuff there, and 1.1 to Tessa's house.
Okay, so we
So we used it for treatment beds in different areas. So that money's not just sitting waiting to go to something in Andrews Goggin.
Thank you.
Thank you. Okay, I just have a quick chairperson's report. You all received the low barrier shelter request. And it had an opportunity, I probably not to review it all, I don't know. But what, at this point, I think what will happen with this is, because we had in the second round of grants, as you know, awarded funding to the low barrier shelters. And so that conversation will come up as we review what happened with that round and what ones will determine to continually fund, or which ones will have ended and which ones will go out to RFP. So unless you have specific questions later on in regards to this conversation about the low barrier shelters will be part of the conversation where we discuss the other grantees that were awarded in. It's actually the second cohort, but the first time we actually RFP'd. Does that make sense to people? We know it's a very important issue, and I know that the shelters are anxious, but I think in fairness to all the projects that we have on the list, and we need to look again, as we always do with finance, make sure we don't overspend the money that we have, and make sure that we invest it well, that we need to do it in a systematic way. And I think this is the best way to handle that. Any questions about that?
Have we communicated that to?
We will. I think we have already, but we'll make sure that we do that again. Yeah, we've talked to them, at least Chastity has on a couple of occasions. So we are in constant contact, so they understand that. Again, they still currently have a contract with us, so we're supporting them, and this will be part of the conversation as we look at the grantees as a whole moving forward. There is, just so everyone knows and clear their calendars, there is no subcommittee meetings in August. We will resume in September. We're giving everyone the month of August off to do other things. I don't know what that is. And then I just want to quickly remind people that September is Recovery Month. And I would encourage any member of the council. Every county is doing celebrations and doing all sorts of things in regards to Recovery Month. And I would encourage you all to look that up where you are and become part of it and see the celebration of Recovery Month as it is. I know in Bangor we do the Recovery Palooza. Interesting, that. But that's what we do in Bangor. So again, I'm just an encouragement. So that is it for me. Committee reports, we're going to, when did the committee reports do in your report first?
I think we can be quick with finance and program and grants, because in program and grants, we're gonna have one for us too.
Okay.
But on the no committee meetings in August with this Zoom issue where they've deleted all of our stuff, all of the ongoing links that everybody already has that doesn't let us delete off your calendars none of them will be good going forward, and we'll have to update them. And so feel free to delete all of them going forward for right now, and we can start new. And I don't know why we can't fix that. But just a warning.
I don't know why they can't.
So they've
No,
blocked our
like-
account, so we don't have access to anything.
Yeah.
So we can't cancel those meetings. But you all will receive new links. And the next occurrence is we will put a note that this is the new link. But just right now, the links that you have, you'll get an error message when you try to join, but.
Put in the label, like
Yes.
the
New-
new
new
in the
link,
label
yeah.
itself, and then where it'll get the new one, and I'll go to delete the old one, but the new one will already be showing up, and then I'll accidentally delete the old one.
This is why my sister doesn't give up her paper calendar that we all make fun of her with.
But anytime it's like a calendar thing automatically that comes to you from Zoom, it doesn't allow us to even delete it or anything, and that's the obnoxious part.
Thank you, Jessica. So we'll move to finance. Is
Yeah.
everyone?
Yeah.
All right. So Deb, are you still with us here? We're gonna move to finance.
I am still with you. I was delinquent on writing up the minutes from the last meeting, but I am going to do that and give them to Elizabeth to put in the Google Share Drive. So I just want to let you know that if you wanted to review the minutes from our last meeting, they're not quite done yet, but they will be done. Hot off the press, I received a budget sheet from the AG's office just today. So I wanted to let you know that our current balance is $29,330,294.66. That is higher than our beginning ledger balance because we're starting to see a trickle of the smaller opioid settlement funds coming in, which is really exciting. Really happy to see that. The other commitment that I made to the Finance Committee that will also follow up with the larger Recovery Council is that I want to start on a monthly basis or whenever the Finance Committee meets talking about not only our balance but also our obligated funds. So you've got the actual account balance, but that doesn't mean it's all available funds. And we've had this conversation all along. So I'm going to start keeping up on a monthly basis. This is our balance, but this is what we actually have to work with because the rest of the money is obligated. And in addition to that, Sheriff Brackett asked again if we could do some projections out. And now that I'm starting to see some of the settlement funds coming in and getting a sense of what that looks like, I think I feel a little bit more confident about doing that, where before I wasn't quite sure what we were going to see for that influx of funds. So it will still be a little bit of a lot of guesswork, but I can at least give you a sense of where we're going to be over the course of the next few years. And that's what I have for Finance Committee.
Thank you. Questions for the Finance Committee? Maggie?
Deb, thank you for all of that amazing work. One of the things we talked about in that last meeting, I don't know if it's possible, was that this council leave recommendations for the incoming council about the amount to allocate in the next round of grants. Is that something that is like even feasible to chip away at as we look at the projections?
Yeah, we certainly can. And I think also looking at what we decided on for a budget, recognizing it's a working budget, doing that math to figure out with obligated funds, is that something with the influx that would be a good round number going forward, or will we have to start really reducing? And if we do have to start reducing, by how much? So that's all part of that projection work and forecasting work that I am going to embark upon.
Thank you so much. I know that's a huge amount of work. Thanks.
Thank you. Any other questions for finance? Deb, as usual, thank you very much. And if you haven't been to a finance committee, even if numbers isn't your thing, it really is an interesting committee. It really does lay out where our funds are going and where they are. Because, you know, when you look at, when she says how much million is in that account, that's, again, there's allocated money, there's promised money. It's not all that it looks there, but, and Deb always spreads that out in the finance committee very well. Thank you. All right, no other questions. We're gonna move on to programs and grant.
Thank you, Pat. At the Program and Grants Committee meeting in July, we focused most of our attention on discussing the off-cycle grant management, for lack of a better word. So a few components of that the group agreed on was sort of thank you, Maggie, for presenting this in June and others and at the council meeting. And so the council has approved the concept and the RFP structure that has been put together. And now the committee was charged with thinking about a vendor that would do this work. And the group decided that we would rather invite people to participate. So I don't know, Chastity, where we're at with that, but we have selected, I think, Maine Community Foundation and MEHAF to participate. And if that doesn't work out, Chastity, we can talk, but I know that that's the will of the group is to invite people and try to make it simple. Then a few of the members agreed to score those applications or those bids, and then that'll take us into July. We're on recess, as Pat said, so that would be the September and October meetings would be mostly that work. And there's probably a very small chance that we will meet in November because our meeting would be later in November, so we'd have to change it, and I'm not sure that'll be possible. So, Chastity, anything you want to say about that per the meeting? Did I miss anything?
There's a separate off part from this part of that meeting. The other part of it was on the 2-gen piece. We discussed if the committee wanted to ask Health Resources in Action to provide us a quote to also replicate the community coalitions process to do the 2-gen process. Originally, when those two funds were set aside, our goal was always do one, and whatever we did in that one, we would do the next. So the consensus of the group was to ask HRIA to do that. They have sent us a proposal. This was not sent to you guys ahead of time because I wanted to make sure it came from Program and Grants first, that was the recommendation. So for today's purpose, we have their proposal. And it doesn't have to stick to this, but if it's the general buckets that we want, we can vote on this next month. If there's pieces that we think we don't need, we can take them out. When we get down further, like there's a piece about post-award. I think as we're progressing with PCG, we probably don't need to have someone else for our post-award stuff because we have a grant management piece. So we can go piece by piece. It is less than our original contract that we have with them on community coalitions. Our original contract was $50,000, and then we added 19. Sorry, I'm blanking on it, to be able to fully take on the RFP and do the entire process for us. This time around, like some of the background work won't need to be done, like what our former RFP looked like, how the process was, how to figure out the public component. So like some of that behind the scenes beginning stuff we don't have to do. So I think there is possibility to bring this down some. You wanna, go down.
Chastity, just to remind people, the 2-gen RFP is RFPing how much money?
$1 million over 3 years. Sorry. So, well, I'll send this out following the meeting. I guess the biggest thing I ask is if there are pieces that we don't necessarily think we need going forward, let me know so I can bring it back to them to see how we can adjust it, and we can have a proposal in September to review and actually vote on if we want to do it. And then as far as timeline of when we do it, they're willing to work with us for whatever we want to do.
So when Chastity got this, we really didn't have time. In her first glance at it, she thought some of it was that we'd already done. That her concern is, are we being charged again to do work that they've already done? And so wants an opportunity to review that, to make sure that the request is fair. And if all of you, if she sends it to you, if you would do the same thing, look at it compared to they did all the work for the other RFP, whether we need to do it again, or whether can we take that out of this contract, because the total contract seemed high. And so
It's broken into two buckets. There's a grant making side and a capacity building side. So.
Would you mind going down to the capacity building side? Just because I think what they offer, I think is slightly different from what PCG would offer, my understanding. So it'd be helpful just to see it because I think part of what they did to the last one is they provided that pre-application capacity building sessions for organizations who wanted to apply. And then there's and again, I just want to be clear. I'm not saying whether we should do it or not. I'm just saying I think it's slightly different. Like, I think the post-award capacity building and technical assistance is like for the organizations that get funded for how to do the work. Do you mind scrolling down a little bit more so I can see that last bit? So I don't necessarily see that as something that PCG is going to do for us. But I think they're doing like the, collecting the evaluation data. I think it just might be different. And so we can decide we don't want this, but it's not my understanding that PCG will do this for us.
Right, and that's a clarification that we have to determine. Any other questions in regard to the direction of this?
So Chastity, you're just gonna keep working this, right? You're gonna keep working whatever we need to
We're
do.
gonna send it out to you all so you can look at it, and if there's pieces we think we do need or don't need, so we can get them adjusted to bring back for next month. But this is what it's looking at right now.
John?
Just for clarity, this piece is not necessarily directly related to the pieces that Joe reported on, right?
Right, they're two different pieces. Yeah,
So I still have some questions about the other before
we can do that. So the other one was in regards to taking our funding and we already voted on, and asking Maine Community Foundation and MEHAV if they would like to submit proposals into I forget what we finally ended up calling it. But it's those small grants, the mini grants, the urgent funds, kind of thing, and that's what that is. But Todd, your question on it?
When is our, as a expiring council member, when is our last meeting?
November.
November? So I know we can't rush things, right? But I was really hoping to, so I was a little concerned, and I think probably what Joe is talking about as far as timelines go are probably realistic, whether I like it or not. But I was hoping that we could move this process along the best we could. It would be really cool as a council member who was leaving, to see this through. So it's not left for a vote at the next council, or whatever, you know what I mean? Even though the funds may not be going out before I leave, obviously, but if the process is in place, I'd feel more like we've accomplished something. Not that we haven't, but I mean, in this specific regard, you know what I mean?
So Chester, you think that's realistic that in the November meeting we vote on which company we would engage with?
Well, I think that was the goal, and that was part of what Joe was talking about whether we meet in November or not for program and grants, because the technical, like, routine schedule would be after the end of the term. So if we need another program and grants meeting to like finalize and make it happen, we can have one at a different time in November before this council terms out with the goal of trying to have a decision by then. But there's obviously not a guarantee there's a decision by then
Okay,
either.
your last meeting is November 12th. So what we can do is if we have to, we can schedule 2 meetings in October, or one in October and one the first week in November. Program and Grants needs to look at this to decide its recommendation. Or they may in the October meeting say that they're comfortable with the full council making that decision and bringing the recommendation to the full council rather and bypass the piece. I mean, we have the ability to do that.
So again, just to clarify, so I think we're all in agreement that we want to ask these two organizations to see if they, want to make a proposal for us, right? And it would be really cool if we could get that proposal before the end of September, right?
Yeah, we were hoping to have them before the September meeting so that people can score. And the scores were gonna be.
Okay, well, that makes me feel a little better.
Yeah.
I was just trying to understand the timing of
Yeah.
it, so if it jives with the meeting dates, hopefully we can make a decision and get it taken care of before November.
And I'm also gonna be really realistic, like we have a lot of things that we wanna do before this council wraps up, and the capacity to do all those things is not realistic. So,
Okay.
like,
We'll just
we will definitely try,
Yeah.
and
We can just do public comment. Does this sound reasonable, Joe, as chair of the committee? Does this sound like the?
Yeah, and I'm glad that you raised it, Todd. So this is gonna happen. So what I'm gonna do is I will work with Chastity and Elizabeth to get all the meeting. We'll notice a different meeting. So ideally, we won't be in the November. We'll maybe get it. We'll try to get a meeting on the calendar in October, 2 in October if needed. If we don't need them, we won't use them. But that way, we will not be showing up in November, not ready to roll. So we'll have September. First of all, we have to hope they both bid or won bids on the work, and then we'll move it. So then in November, it would just simply be a go, no go vote from the full council based on what we've learned. But as we're learning, we'll brief the full council so that we won't get caught up on that last meeting.
Thank you.
And that I'm going to stop there. Chastity did a nice job at the meeting talking about what PCG is doing. She's given an update on HRIA. There's lots of moving parts, but what we're trying to do, like what Pat's talked about, Deb's talked about, we're trying to like wrap it up for the next council and have recommendations is a strong word, but like documents process from our committee so that we can hand that off to the next crew. And I will leave it at that. Any questions for the committee? Thank you. Back to you, Pat.
And all of us
Can you
going
hear
out.
the thunder and lightning here? It's like dark and rainy and like crackling. And...
No, it is sunny in Augusta. I'm looking at the sun, Joe. So keep your weather down there. We're fine.
Yeah, it's
right
like
here.
blackout and the rain is so heavy I can't even see. So
We are fine. So keep it there. Don't send it our way. I am gonna
Thanks.
suggest maybe we have like coffee, all of us getting off at the committee so we can, kvetch. Anyway, thank you very much. Do you want to do this first here? Or do you want to go ahead with this?
you just did that.
No, sorry.
No, we'll do this last.
All right, so we were going to do the governance.
We're doing the orientation last, so.
Okay, we're doing the orientation
Thank you.
last. So at this point, we are going to move to staff reports and the SSP.
Yeah.
All right, so I'm gonna turn it over to you, Chastity.
Yeah.
Sorry, Paul, just one more week.
So we've been all over the place in how to approach this. And, last month we talked about doing tiers to try and figure out the possible inequities. And then we sent it to finance to talk about the full amount of things. And then we went to finance and talked about how doing tiers could actually be more complicated, and we need to just keep it simple. If programs aren't specifically complaining about the inequity, why are we worrying about it at this point? So we left finance with, bring two options. One that is just redoing the ones that we have at the baseline that we already did. And then the second option was the same, but just a bit higher. You want to go to the second part of it. So in this is right here is just the very basic of what we are currently funding for certain service programs. I should probably open it on my own thing so I can, no, I don't need it. I'll pull mine up so I can see. And overall, it comes to just under 3 million and 2.897 over 2 years. With that, for the most part, all of them, it was 75,000 per site per year. There is like some outliers, like when we received money back from year 2 of one of our programs, we split it up and added on to some of those contracts. And then we have one that is like a major outlier because they received significantly more than all of the other SSPs because they applied and went through our grant process, so they were done separately. So that throws this amount off, the Skowhegan program. That program in particular, their contract with us is through next fall. They are not yet certified. They have been working towards that. And for those who don't know, Skowhegan is like the original SSP ordinance in Maine. So like they've had some challenges that they've been working through. And so they're working and they're in process. So at this point in going forward with the recommendation, I am not including an amount for them in there. And I'm just looking at it as everything else that we have. But they are a little bit more than everyone else. You can go right to page 4. The second part is information they already have.
So then I'm included in that 2.8 million you just.
In the first one of what we're currently funding, they are.
Yeah, they
When
are.
we come to the recommendation, I'm gonna pull them out. So right now, 2.9, 18 sites, 12 organizations, and then that one outlier. So I'm gonna go forward. And what we can look at for options is, the first option is we do a renewal at just the regular 75, no change. And when we take out the outlier, we're looking at 2.55. Option B would be the same thing at 85,000 and it's 2.89. So basically what we're already doing now with that one outlier, a couple things is, I asked about changing it so we're not saying X dollars per certified site, because especially with the current landscape, if we have someone who needs to get like 4 certifications for different outreach sites in a city, like that's really challenging to give a single program. Like Bangor, you have 4 locations, but you're the same organization. Like, should we give you $300,000 for one program to move throughout the city? And I don't think we'd be able to keep up with that. So just to change it to S dollars per town or city of SSP certification, and it keeps it at what we already have is just renewing all of them, and the amounts are either 75,000 or 85,000. Neither of these options has a set aside for if new programs come on, which there is a possibility of up to 4 to 5 is what the CDC had told me. Whether that's still the case, I am unclear. And what we talked about at finance also was, when we think of if there are inequities, why can't programs just come to us and say, like, we have this really huge program, but just one site and this isn't enough? Like, come to us, and if they need more support, we'll figure it out. So we don't have anything set aside for any of that, and that's not figured in here anywhere because I didn't want to identify that amount because I don't know how much people want to do. And I still really want to keep it simple.
And again, it doesn't, if one of the SSPs has something innovative or new, they're always eligible in further RFPs to apply. So if this money was there and they had something innovative that wasn't included, they can still do that. I just want a clarification. So there's 12 organizations. And within those 12 organizations, we're recommending we fund 18 sites.
That's what we currently already do.
That's what we currently do. With this new option,
It's redoing the 12, it's redoing all the ones we currently do.
Correct.
Nothing new. We already fund all of them.
okay. Questions in regards to this?
And to see it, how it breaks out for amounts per sites. That's what the last page is. It is hard to see. We will send it to you so you have it too. The first one, it's exactly what we did when we started this. There are a few that, only came on in year 2, so now of our first round. So now they would be adding on 2 new years.
And this, when you say per site, it's really like per program.
Yeah.
For geo-specific program.
Yeah.
And for 2 years. The numbers that you're looking at is 2 years.
Can I just ask one quick question about the proposal to do it by, like, to think about geography? What would that mean exactly? It's just like changing the language in there about geography so they can do different things. I didn't totally understand that part. If you could just.
Yeah, it would just be changing the language to say, I wrote it down, I don't have my thing, but per town or city, they're certified to operate it. So it still has the certified, it's just narrowing it to just the town, so it's not one organization with multiple certifications in one town getting $75,000 3 times for the same.
Right. If we picked on Needle Point Sanctuary, they're located in Bangor. If Needle Point Sanctuary had 3 different sites in Bangor, we're not funding 3 different sites.
Got it.
We're funding Needle Point Sanctuary at being in Bangor with that amount. Is that correct?
Yeah. And I mean, you don't have to do it at all. You can just completely renew the contracts we have as is at the original baseline amount, or increase as is. It's kind of just a precaution thinking about going forward. So we don't end up being tied to too many more that we don't have money set aside for.
Questions?
Are you asking us to make make a decision on this today?
That would be nice. If you're comfortable.
My only hesitation one of my hesitations are, I know it's only a projection, but, I don't, where do these funds fit in the amount of money that the council may choose to put out next year or the year after, and I would feel better if we had some projections, ones that the finance committee is working on, similar to what Ben did for us way back when, even though we know those figures were speculative. Based on what we know now, that's just me, and maybe I'm overthinking it. How does this, assuming the next council is gonna do another round of funding, what is this, if we earmark these funds now, what does that do to that? I'm not saying we shouldn't do it. I'm just trying to understand what's the impact on the bottom line?
I'm gonna let Deb answer that in a second if she can, but again, I would assume that if we entered into a 2-year contract, that no matter who's sitting on the next council, they would abide by a 2-year agreement. So that is, but Deb, I believe in the budget some of this money was set aside when you talked about projections. Am I correct with that?
Yeah, there was a discussion. Well, it's not that I set it aside, it's that I factored it in. Because there was a lot of discussion about the sustainability of SSPs and what we were going to do with SSPs. So it's factored in, but I could do, I don't know what the right word is, a copy budget, a shadow budget that breaks it out. If that would make things easier for people to look at.
In their contracts and
The first ones are in November.
November.
Go where that's coming from.
Deb, you had your hand up?
I do. The one thing that I know, I'm a broken record, and I'm not opposed to funding the SSPs. I realize that they don't have a lot of alternative options. So I think we need to keep that in mind, where some of the different projects do have alternative funding options. SSPs are not necessarily in that same category. At some point, there will be a funding cliff. So I just want to continue to remind us that over time, we won't have, again, I think a little bit to speak to what Sheriff Brackett you might be saying is, over time, as our coffers get smaller and smaller, this number that doesn't look so large now is going to seem bigger and bigger and bigger. So I don't know if there's a way to mitigate that or not, but it is something we do need to consider over time. Maybe not for this vote, but for the next council.
So when Deb originally put together a budget and we had to do the allotment planning for the fiscal year for finance, what we put in there for to be determined contracts and renewals was $6 million for this fiscal year. The amounts that you're looking at, that 2.55, that's for the next 2 fiscal years. So it's really 1 point, whatever.
And I think the point, I think I understand what you're saying. So if there's, using that number you just said, the 6 million, and $1 million of that next year will be earmarked for the SSPs, and then $1 million the year after. Right, but as far as the budget you're referring to, so that would leave about $5 million for other projects or whatever the council. That's what I was just trying to get my mind around.
Yeah.
If we earmark these funds, again, which I'm not necessarily opposed to, what is it, how does it, what flexibility does it leave, or what, what challenges does it present the next council with other projects and stuff going forward, that's all.
Okay.
As like representing the litigating subdivisions and representing one of the organizations with the largest SSP site, I do want to get it on record that a tiered system would have been helpful and beneficial, but I recognize and appreciate the thought that went into the overall decisions around that. And appreciate that there may be opportunities in the regular grant funding process, and that we keep that in mind, particularly as we think about some of the challenges on the harm reduction HIV Hep C continuum, that there may be spaces for that larger grant making process to address some of those areas where the additional funding could make a difference. But I will say, I think this will be very well utilized in the community and will have life-saving impact.
Yeah. Liz, Deb, do you still have your hand up too? But we'll go with Liz first. Thank you,
Yeah.
Maggie.
Thank you. I actually wanted to echo, I don't want to stall this out from supporting the SSPs now, but I do hope that people think about the number of people who will be impacted, like having a base amount for everybody and then adding on for folks who really see an incredible amount of people, like Portland Public Health and perhaps the Bangor service area, like in the areas where people see a ton of people, they need more resources. So I guess I would be down with the tiered system in the future as well.
Yeah, and I think in an ideal world, if we had a finance person that could figure this all out for us, it would happen, but it's, as we started pulling it apart, It just was like, it was just getting way too complicated because none of us have that expertise to be able to do that, to measure populations versus this. Again, it seems simple, but it's not. Deb, you had your hand up again, please?
Yeah, I would just say one last comment though about this is, as Chastity said, you're talking about 1.5 million each year. And when you look at this spreadsheet and you look at the number of programs that are going to be funded, it's really not a big ticket item. So just thinking about that also for projections down the road.
Well,
The syringe service programs right now are being assaulted in the press, by referendums, by city councils. I think it's really important that we show our support today for them, and I think that will speak to the public also.
they're an evidence-based program that saves lives. And they're, you know, I think most of the council members here agree that they are making a difference in saving lives in the community, and they are, a lot of education needs to be done in a lot of communities in regards to exactly what services the SSP do and how they are evidence-based. It's not just, it's just not there. They just don't hand things out. So again, I am one of those people that believes by supporting this, we're giving, at least for me, giving the message that we support these programs in moving forward, because they have been in the press a lot. And again, as you saw today with Sanctuary, the work that they're doing, trying to employ the unhoused and try to engage them in recovery practices. And we could see just even on a small level how that was successful. But again, so I'm looking to the council if they're comfortable with taking a vote today, or do they want to table it for next month, or are they comfortable taking a vote today?
For a vote.
You can make a motion.
I make a motion that we award the 18 syringe service program sites 85,000 per year for 2 years for a total of $2.89 million.
Do I hear a second on that?
Second,
And that was Liz?
yes.
Okay, thank you. Further discussion? Tess?
Thanks, Pat. I just wanted to state on the record that I will be abstaining from voting due to the fact that my employer is on the list of the certain service programs that will be voted on.
Appreciate that. Same.
No, my previous employer is on, but I'm okay.
Yeah, you're employed by the government now, pal. Reagan.
Hi, Pat. Thanks. Just the same as Tess. I'm the board chair of one of the organizations on this list, and so I'll be abstaining from voting.
Okay. I appreciate all of you that expressing your conflict of interest in taking your roles as it should be and sharing that. All right, if there's no further discussion on that, we will take a roll. Betsy or Chastity doing the roll?
You want me to do it, Betsy? You got it?
Betsy's muted.
No, if I would turn on my microphone, I vote in the affirmative. Deb Poulin,
Yes.
Holly Stover.
She's left the meeting.
Okay, Jamar Williams,
Yes.
Joe Everett,
Yes.
Liz Blackwell,
Yes. Yes.
thank you. Maggie McLaughlin, Melissa Hackett,
Yes.
Pat Kimball,
Yes.
Paul Vinsel.
Yes.
Reagan, you said you were abstaining?
I'm
Tess
abstaining.
Parks? Todd Brackett.
Yes.
All right. I have a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10-2.
So motion carries.
I got a 9-3 or 9-0-3. 9 yes, no nays, 3 abstentions.
Who abstained? Because I'm,
Tess, Reagan, Maggie.
oh, okay, okay, you got it. Sorry about that. I didn't hear her say that.
It's okay. We've been audited and we're okay. I believe the motion carries. And I thank all of you very much, and I think the SSPs will be grateful that you support the work that they do. And I thank you on that. All right, so we're finally going to get, I think, to the governance.
Wait, there was
No.
an update before you moved.
Oh,
to that,
an
but it's
update.
still on us. The Community Coalition's RFP that closed, there were 50 applicants. HRIA is working through to make sure, you know, all of the ones we have are qualified, like doing that baseline check. And yeah, so we got more than we expected.
50 applicants, and how many grants are there? They said.
50. 5 to 8 is what we put would be awarded. I mean, honestly, some of them, I think it's questionable that it's the right one. Obviously, it's like a really challenging time where people are applying for anything to see what sticks, so it might not fit, but there's gonna be a lot of really good stuff too.
Great. Thank you.
Now you can pass it to Paul.
You sure? Thank you.
Oh, wait, no, I'm sorry, I forgot. There was a brain cramp and then I looked up and saw Liz and it reminded me. Part of that prevention piece, the community coalitions piece, I'm so sorry. It's been a rough day. It's been challenging to get enough outside reviewers with conflicts of interest and summer. And one of the pieces in the original recommendations was having the ability to compensate reviewers. And we never did anything with that. We never said it. And we have been asked if we're only going to have roughly 9 total reviewers, 3 of them are MRC members who cannot be compensated. And then, so 6 external, and not everyone may necessarily take a stipend if it's because they may be, you know, paid for whatever other reason. But is that something the council is willing to approve, is providing stipends to
Council
external
members
reviewers?
council members cannot take a stipend.
Right.
You're only asking if you have outside reviewers, if we would approve stipends for outside reviewers with the grants.
How much would that be?
Because we got so many things and there could be a lot, the recommendation from HRIA was up to $500 per
person.
Yes.
Okay. Melissa,
For review.
is that Melissa? She's got her hand up, and then Liz.
Yep. I was just going to ask also what we had talked about for a stipend. I think it would be helpful. I don't have it in front of me, but just to remind the council of the estimated number of hours that would be for, as people think about that amount. I don't have it right in front of me, but I just think that might be helpful.
I was just doing math, if that's like accurate. It'd be
Yeah,
like
it's a pretty
19
fair
per
number.
cohort, at least an hour per, well, maybe 30 minutes per work, and on the short end to an hour, depending on how intense the review is. So it's like at least a half a week of work.
To about 40 hours of work.
I think the estimate was more like 20 to 25. That HRA gave us in the meeting the other day, because they would only each reviewer would read somewhere between 10 and 12. probably. And actually this only really is for one or two people because we actually just found we have some others who are doing it as part of their work. So I think it won't be an incredible amount of people, but it could be helpful in expanding our geographic area.
So you're looking for, do we need approval on that to pay reviewers who are not currently council members, approximately for 25 hours of work, approximately about $500 piece?
I think we just need the council to say they're okay with doing that. We're not gonna necessarily pay out, it's gonna be more realistic to have HRIA do that, and they will bill us for it.
Okay.
But the council needs to approve that because we didn't put it into the original contract.
So do I hear a motion that the council is willing to pay stipends as requested by HRIA for outside reviewers?
So moved.
It's been moved. Do I hear a second?
Second that.
You just change the language, motion from requested to, is it requested or is it recommended, suggested?
Recommended to provide stipends to outside reviewers who are not doing so as part of another paid we had. Liz, what was the language that we talked about? It was in the recommendations originally, right? If they're not being paid by their their job. Thank you.
So Todd, will you?
Yes, I modify my, if
I'll-
I need
I'll
to,
do a
I would
motion.
modify my motion to fit what was just said.
And then, Paul, are you seconding the modified motion?
Yes.
Is there any further discussion? Todd?
Just quickly, I think it's important to, if it helps incentivize the process and helps us move this process along so we can get these funds out quicker, I just think it's money well spent. I just want to put that out there.
I think it will also give the reviewers a feeling, you know, that to put more thought to, you know, not drift your mind somewhere else, but put your thought right to that.
Me.
I'm gonna abstain because I think some of my team members may be reviewers and don't want any appearance of conflict of interest.
If there's no other discussion, Betsy, will you call a roll?
I certainly will. I will vote in the affirmative. Deb Poulin,
Yes.
Jamar Williams,
Yes.
Joe Everett,
Unfortunately, I had to step away, so I'll have to abstain. My apologies.
Liz Blackwell Moore,
Yes.
Maggie McLaughlin, Melissa Hackett,
Yes.
Pat Kimball, Pat.
I said yes, I'm sorry.
Oh,
Just checking my time to make sure Paul had time.
Paul Vinsel,
Yeah.
Reagan LaRochelle,
Yes.
Tess Parks,
Yes, Betsy.
Todd Brackett,
Yes.
3, 6, 7, 8, 10-2.
And the two motion carries. Thank you very much.
10-02.
10-02, but yeah.
Yes.
Wait, then 1-2, right? Because I abstained. Whatever.
Two abstain.
Yeah, okay.
Two abstains. Yeah. Thank you very much. All right.
Now I'm actually done to give it to Paul.
Okay, Paul,
Been a day.
you have till approximately 4:30.
Well, I won't take up that whole time.
Well, no, your whole presentation.
So this is-
till 4:30.
This is the orientation, the start of the orientation. We have 3 topics that we're gonna talk about today. So first I'm gonna talk about the medical history of the overdose crisis. And then Tess is gonna give us. Tess, are you giving it today or next September?
I'm okay with not presenting today if we need more time and space for the other topics.
Okay, the history of the settlements and litigating parties, I believe that you, Brendan?
Yeah, I was gonna say something similar, which is to the extent we have limited time, feel free to take up, like, don't cut your presentation short or don't.
Okay. We'll
That's-
play it by ear then.
Mine is well known and, you know, I've done it many times, so
Okay.
you should do the full presentation you were intending to do, and I'll adjust.
All right, thank you. So the medical origins of the opioid crisis, I wanted to do this because I wanted to stress why are these settlements occur? Why did the pharmaceutical industry, the drugstores, other places, why did they get sued? Next slide, please. So it all starts in 1980, though in 1980, no one knew. No one knew this was going to occur. In fact, no one even read this letter. This was a letter to the editor of the New England Journal of Medicine. It was one paragraph. And it talked about this fellow had reviewed charts of 11,000 inpatients receiving opioids in the hospital. And 4 of them developed addiction. There was no further data given. There was no evidence given. It was just this kind of opinion, 1-page paragraph in the New England Journal of Medicine. No one even read it. However, later on, about 4 or 5 slides later, we will see that the pharmaceutical industry used this letter to convince physicians that it was safe to prescribe opiates for people with chronic pain. Next slide, please. Also, 1986 article, this was more of a case review, 38 patients on opioids for chronic non-cancer pain. 2 had problems related to prior substance use. I actually had never heard of this article, but it came up in my research for this. But that's next slide. This is where we started getting into the meat of it. In the 1990s, this society formed, the American Pain Society. And they put out guidelines for treatment of acute non-cancer pain. They did stress multimodal treatment, but they stressed that pharmaceuticals were the primary treatment. Now, where did the American Pain Society come from? It was completely financed by the pharmaceutical industry. Purdue Pharma was the biggest contributor to this. So the pharmaceutical company was giving guidelines to physicians on how to treat pain. Also, and stressing that pharmaceuticals are important for it. Next slide, please. This really got some storm because of all of this, because of the American Pain Society. There were all of these letters to the editor, all of these opinion pieces saying that we were not treating pain appropriately. So the American Pain Society developed this idea of pain as the 5th vital sign. So in medicine, there's 4 vital signs. There is pulse, respiratory rate, blood pressure, and pulse oximetry, the amount of oxygen in your blood. Those are all readily objective findings. You get those in triage, and you do get those by a test. Well, they established pain as a quantifiable measure, and how they got that was they asked the patient on a scale of 1 to 10, how bad is your pain? If you think about it, that's completely different than what your pulse is, which is objective. But this idea of pain as a 5th vital sign really took off. In 1999, the VA system created it, made it mandatory for all of their hospitals and their physicians and healthcare providers. And in 2001, the Joint Commission took this up. The Joint Commission they inspect hospitals every 2 to 3 years. And if you do not pass their inspection, the hospital loses Medicare, all federal funding, Medicare and Medicaid. So it's really important for a hospital to pass their funding. Well, the Joint Commission said you have to use pain as the fifth vital sign. In the emergency department, we were tasked that we had to ask every patient, no matter what they were there for, what was their pain before, when they got there? What was their pain after? Did we address their pain? If we did not, we would not pass the Joint Commission and our hospitals would lose all federal funding. Next slide. Purdue Pharma, so OxyContin was approved by the FDA in 1995 for the treatment of pain. This took oxycodone, which we were using fairly frequently for acute pain, and this made it in a time-released formula so that it would last longer. It was marketed by Purdue as a non-addictive treatment of pain. They marketed it so aggressively. They hired lots of pharmaceutical representatives to come to hospitals, to come to physicians' offices, and really push this drug as a non-addictive. And what they would do is they would say that this gentleman had a study in the New England Journal of Medicine in 1980 showing that your chances of getting addiction if you were treating pain was less than 0.04% based on that one paragraph letter to the editor. They wouldn't show you the letter to the editor. They would just say that this doctor had this study that showed this. There was no data to support that, but they didn't present that. Next, yes, Brendan.
Earlier, you talked about chronic non-cancer pain. Is it worth talking about what kinds of pain Purdue Pharma's salespeople were promoting OxyContin to treat? Is there a significance to the phrase chronic non-cancer pain?
I think there is, because acute pain is one thing. Acute pain is going to last a few days. You know, you had your tonsils out, you had some surgery, you're going to need some pain medicine for a certain amount of time. What the pharmaceutical companies were doing was recommending opioid pain medicines for this chronic non-cancer pain, chronic back pain, chronic abdominal pain. These things are really common, and a large segment of our population has chronic pain. It turns out that when you actually do studies, opioids don't help chronic pain. Studies that have come out now show opioids don't help chronic pain. In fact, they make chronic pain worse. We didn't know this in the 1990s because these studies weren't done then. But now we know that. But though the pharmaceutical companies would say that opioids are safe for chronic pain, they had no data to support that. Does that answer your question? Thank you. Next slide, please. Later, congressional hearings would reveal that Purdue Pharma knowingly misinformed physicians and the public. So Purdue Pharma knew that these medicines were not safe, yet they marketed them as safe. Next slide. So pressure from the pharmaceutical companies included financial incentives for physicians. They would pay for physicians to go to some island in the Caribbean for a conference on pain, all paid for by the pharmaceutical industry. And of course, it was all a marketing idea to get them to prescribe. They never offered me to go to the Caribbean for a week, but I maybe would like that. The incentives include honoraria, so they would pay people to speak on pain to their local medical societies, paid trips to conferences, meals, and paraphernalia, all sorts of stuffed OxyContin toys. Next slide. Another thing that happened around this time, hospitals wanted to figure out how do they measure quality of care. It's really hard to measure quality of care. So they came up with this idea of customer service surveys that they would give to patients. And insurance companies wanted these, regulatory companies wanted these so that the hospitals could prove that they were giving good care to people. In 2005, the hospitals were required to report the results of these patient satisfaction surveys or lose reimbursement from Medicare. And hospital systems would then say, well, your salary as a physician now is going to be based on your scores of your patient satisfaction. And that happened to all of us. Well, it turns out that on these patient satisfaction scores, 4 of the questions were strictly on relief of their pain. So if you weren't relieving their pain, you got paid less. Next slide. So why did overprescribing occur? Well, physicians definitely increased prescribing of opioids. One was a desire to treat pain. Physicians really felt at that time that that was the right thing to do. We wanted to treat pain. We were told that this was safe. We wanted to relieve suffering. There were incentives from the pharmaceutical industry we talked about, pressure from regulatory and licensing agencies. I can tell you, I was reported to licensing agencies in the state I was working in because I was not treating someone's pain aggressively enough in the emergency department. And then there were pressure from hospital systems affecting physician salaries, which I talked about. Now, I put then a little space. Yes, there was some unscrupulous behavior by physicians. There were some physicians that saw this as a really great way to make money. And they just opened places and they were just, people would line up, they'd see the physician and say, you're having pain, write a prescription. And they drop their $100 down on the desk and go to, and then the next person would come in. That did occur. Next slide. Prescription of opioids, because of all this, 1997, we were down here. A steady increase until about 2011, 2012. Remember those dates, 2011, 2012. So this was how many tablets or patches or milliliters were prescribed, that's the blue, and the oral morphine equivalence is in green. So when we're figuring out how strong is an opiate, we do it based on something called the morphine equivalent. Morphine is the quintessential opioid. So if you're going to give 10 milligrams of morphine, well, how much Dilaudid did you have to use? How much OxyContin do you have to use to get to equal 10 milligrams of morphine? That's kind of what that. And you can see just a steady increase. And then you see kind of a slower but steady decrease. Next slide. So overprescribing of opioids leads to an increase in opioid addiction. That's what we're all here for, as well as increase in opioid deaths due to opioid overdose from prescription opioids. So we were prescribing too many opioids. People were becoming addicted. They were dying of overdose of those. Next slide. As we were prescribing more and more opioids at higher and higher doses, because we were told by the pharmaceutical industry that higher doses were better, the cost of those increased. OxyContin was never really cheap. Oxycodone, like that I can just prescribe 5 milligrams in the emergency department, it's really cheap. But when you get into those long-acting formulas, it's not cheap. The cost of the prescriptions became higher than the equivalent cost of heroin. So as you were getting higher doses to people for chronic back pain that they would be on for years, if their insurance, if they didn't have insurance or their insurance company wouldn't pay for it, it was actually cheaper for them to go to the corner and buy heroin and use that. So that started to occur. Also, around 2011, 2012, where it reached a peak, physicians started to realize we were making a mistake, that we had really kind of let the cat out of the bag, and we have to start decreasing. So a lot of physicians started decreasing prescribing of opioids, but unfortunately, their patients now were addicted to opioids. So if you've got a patient you've got a patient that's addicted to opioids and you're prescribing those opioids and you just stop the prescription, what is that patient going to do? They're either going to suffer horribly, which we know from the science of addiction is really difficult to do, or they're going to go out and find opioids. They're going to find, and at that time, the opioid that you could get on the street was heroin. So that's what they did. Next slide, please. As the use of heroin increased, then we started seeing an increase in overdose deaths, not due to prescription opioids anymore, but now increased prescription opioid overdose deaths due to heroin. So now the opioid overdose deaths due to heroin surpass the number of overdose deaths due to prescription opioids. I'm going to show a timeline at the end where all of these things occurred. Heroin is a natural product. It's a natural product from the poppy plant. So in order to get heroin, you have to grow your poppies and then you have to process them. That's limited because how much land is available for farming? Where can you grow the poppies that you need for heroin? What are the weather conditions? What's the growing seasons? What's the government doing in that in terms?
Are other people not hearing things? Okay.
Not hearing things.
You guys can still hear us though?
No.
No.
Okay.
Okay, they can still hear you.
Okay. So Afghanistan, of course,
Nope. Now we can't hear you again. We're not hearing you through Elizabeth's. Chastity, if you unmute, we might be able to hear. Still nothing.
Still nothing.
We can't hear you.
And it was really good.
I know. It's working fine. Are we just gonna wait it out? Until 4:30?
What do you suggest?
Oh, I don't know. I just was wondering.
I don't want to be rude.
I know, I don't want to be rude either, but
I
I'm
have
just
to
gonna,
jump to I have to jump. I have to head to another meeting. So
I think we may
okay.
need to bail. I'll put something in the chat. I said that we can't hear you, but I don't think they can hear us either.
No, I can finally hear now, but we completely lost everything in the room.
Oh,
Oh,
So,
wow.
Paul's still talking and presenting, but we completely lost everything in the
Oh,
room. We will share the slides and
great.
we don't know what happened.
let Paul know that we enjoyed what we
yeah, it
heard.
was
Yes,
really
please do
good.
tell Paul it was very interesting.
Very
He
good.
was very much in his
Fantastic. Yeah.
element. Thank you.
Thanks,
all.
everyone.
Thank you.
Thank you.
Bye-bye.
Bye.